Hi and welcome back. For today's video, I'm going to be talking all about pediatrics, conditions and disorders that tend to pop up on not only the nurse practitioner boards exam, but also perhaps in your practice. There's a lot to cover here. I debated about dividing it into two parts, but I'm hoping to make just one video work. I'll discuss vaccines, behavioral problems, pulmonary, cardiovascular, hematological problems, GI, GU, musculoskeletal, and then dermatological conditions as well, all in regards to the pediatric population. At the end of the video, as always, I did include 2 dump sheets to help supplement your studying, comprised of all the key points and those clinical pearls. Don't forget to leave me any questions that you might have and subscribe to this channel if you have found these videos helpful in your studies. And now on to pediatrics. Alright, so I'm going to start the discussion today on vaccinations, and this first slide here is all clinical pearls that you should just know. Administering a vaccine greater than 4 days before it's due is invalid, so that's a no-no. Live vaccines, they either have to be given on the same day or a minimum of 28 days apart. And then it's really important to understand live vaccines because you cannot give them to children younger than 12 months because we're not really sure of how their immune system is yet. So we don't know how they're going to respond or if they're immunocompromised, because also no live vaccines should be permitted in the immunocompromised population and then also in the pregnant population. So live vaccines, those include the varicella and the MMR. And also an important point here is that because those vaccines are live, they might cause a slight fever, which is a possible expected side effect, and we just want to educate our parents on this in case it does occur. And then some other clinical pearls here: the HPV vaccine and the vaccine for meningitis and the Tdap have all been known to cause syncope in adolescents. Refer to the CDC if you are questioning any vaccine recommendations. For example, if someone is asking about vaccinations required or recommended for traveling. And then for monitoring for allergic reaction, the CDC recommends that monitoring for 15 minutes after administering the vaccine is sufficient. Egg allergy is not a contraindication to the influenza vaccine, and the reaction, if the reaction to the egg allergy is hives, then you will just go ahead and administer the influenza vaccine as normal, monitor for your 15 minutes. However, if they have a reaction such as angioedema or anaphylaxis to eggs, and they still want you to administer the vaccine, but they say to do that in a place or a facility that's capable of handling anaphylaxis, God forbid that does occur. So this slide here is just some more specifics in regards to vaccination schedules. Important to note though here, for the exam, the questions aren't specific about scheduling, because those are subject to the change. Instead, the questions are more about the vaccinations themselves, side effects to look out for, contraindications. So just important to think about when you're studying. But so Hep A is now routine and it's given at 1 year. Hep B, this has been like the same forever. So this is fair game for when they ask you questions about scheduling, because it has not changed and there's no intention for it to change. It's given on day 1, like of birth, 1 to 2 months, and then 6 to 18 months after your first dose. Important is that if mom is Hep B positive and gives birth, then the newborn should be not only receive the Hep B vaccine just as usual, but they should also receive hepatitis B immunoglobulin. The DTaP is for less than 7 years. Tdap, that's the one that we are probably more familiar with. It's given at 7 years or older, and then a booster every 10 years. And every pregnancy, preferably between 27 and 36 weeks, should get a Tdap. For the pneumonia vaccine, there's the PCV13 and then PCV23. And it's important to know that there's a few things here that are important to note. One is that giving this vaccine helps to decrease the risk of strep pneumoniae, and this is important because this is a major cause for acute otitis media and pneumonia, obviously, in these populations. So that's important. And then important to note is the PCV23, which is for high-risk populations, and that includes patients with leukemia and then patients also with a cochlear implant, because this increases the risk for infection. Important to note is that asthma is not indicated as a risk for requiring this PCV23 vaccine. There's the rotavirus vaccine, polio, MMR, that's contraindicated in the allergies to neomycin or gelatin. Varicella, influenza. That's for 6 months or older. It's an annual vaccine. If you're in between 6 months and 8 years and receiving your first influenza vaccination, CDC says to divide it into 2 doses and separate it by 4 weeks. And then the last HPV. This is an important one too, because this is a vaccine that this prevents cancer. It's given up until 26 years old, and then if they haven't gotten it by then, we'll skip it. It's more effective if it's given before the patient is sexually active. If it's not, if they've already been sexually active, then they say 3 doses. If they have not been sexually active, 2 doses is sufficient. You'll go ahead and administer this vaccine without checking pregnancy status. However, if the patient is knowingly pregnant, then you do not administer this vaccine, and this is per CDC. All right, so on to behavioral. So this is going to be just a quick discussion on ADHD and ASD. ADHD includes hyperactivity, impulsivity, and inattention. Hyperactivity and impulsivity, those pair together. They usually appear by 4 years old, with the symptoms then peaking over the next 3 to 4 years afterwards. Hyperactivity, it tends to improve after 8 years old. However, inattention tends to be a lifelong problem. And these kids might struggle then with academics, socially organization, get off task easily, seem distracted. The DSM-5 diagnostic criteria is an onset of symptoms before 12 years old, lasting more than 6 months, and the behavior persists in 2 separate environments minimum. And this is to make sure that it's not a problem with the environment. Pharmacological treatment is going to be indicated for children 6 years and older, and the first line of drugs are stimulants. There's example of amphetamines. This is a Schedule II substance drug. It has a high potential for abuse, so we'll want to monitor our patients very closely. And then if they have any comorbid psych disorders, then it is encouraged to refer those patients to psych. ASD, this is related to an impairment in social interaction and communication. Routine screening is done at 9 months, 18 months, 24 months, 30 months, but the important one here is at any time also a parent has a concern. Red flags for ASD include speech delay, regression in social skills, or a sibling with ASD. There's lots of screening tools available for free. There's one example here is the MChat. I looked it up real quick. I even have it on the next slide just so you can see. Really easy to find. We're going to refer these patients as well. This is a popular screening tool used to assess for ASD, the MChat, the one I had mentioned in the previous slide, and you can just take a look at it. It's 20 questions, easy to follow, and very useful for screening. All right, so on to pulmonary. A brief discussion here first on asthma, and this is in regards to children younger than 12 years. I actually did another discussion on COPD and asthma, and that is for 12 years and older, as they're treated the same, but this is in regards to 12 years and younger. So approximately 80% are diagnosed before age 5, and they present with symptoms like cough and wheeze. Intermittent exacerbations are precipitated by things like respiratory infections, exercise, weather changes, tobacco smoke, allergens, stress. And then up to 80% of children with atopic dermatitis develop asthma or allergic rhinitis. So diagnosis is made by evidence of an airway obstruction. We can see that on spirometry, especially if it's acutely reversible after use of a bronchodilator. However, in this population, absence of either does not exclude diagnosis, and a trial of asthma medication is totally indicated if the patients present with symptoms suggestive of asthma. Spirometry is recommended by the National Asthma Education and Prevention Program for patients 5 years and older. However, for that population younger than 5 years, they might not be able to do spirometry, and we still need to trial them on the medication. Also on this slide then is going to be medications. It's divided from 0 to 4 and 5 to 11. I would not stress yourself worrying this. Obviously, we know that the SABAs are the first go-to, and that's as needed. And then we'll step up to inhaled corticosteroids, and then so on and so forth. You can kind of review it, but I would not stress yourself trying to memorize that. You don't need to. If you feel like you need to step up therapy with your patients, before doing so, check adherence with their medication, check their technique, make sure they're using it correctly, and then also check their environment. If you're thinking stepping down, make sure that their asthma has been well controlled for at least 3 months. And then if they have exercise-induced asthma, then they should do 2 puffs of their rescue inhaler about 5 to 20 minutes before beginning their activity. So bronchiolitis is a respiratory viral infection that occurs before 2 years, normally before 12 months. And they begin with symptoms of an upper respiratory infection that then spreads to the lower respiratory tract, results in things like wheezing, crackles, increased respiratory rate, and fever. RSV is the most common cause of bronchiolitis. If the patient is stable, they can normally be managed outpatient and no pharmacological interventions are needed. Generally, it's self-limiting and typically resolves in about 2 to 4 weeks. If they experience a persistent increased work of breathing, then we need to be monitoring for things like nasal flaring, retractions, fatigue, decreased appetite. All of these things could be indicating that the patient is experiencing respiratory distress and they should be referred to the ER. So cystic fibrosis is an autosomal recessive genetic disorder that causes an abnormal increase in the loss of sodium through sweat. These patients will have symptoms like a persistent productive cough, increased sputum production, hyperinflation of the lung fields can be seen on x-ray, and repeated bronchitis infections that eventually turn into bronchiectasis, which is permanent lung damage to the bronchial tubes. So this is a really horrible disease. Many also develop things like sinus disease, pancreatic disease, male infertility, reduced bone density, weight loss, greasy, all of these things. It is a multi-system disease. So pulmonary function tests will show airway obstructive disease, and the diagnosis is made with a sweat chloride test. And if the first test is positive, then you confirm it with a second positive sweat chloride test. And I include here in the parentheses, so you don't need to worry about this, but a 60 or greater is considered a positive result. So siblings of patients with cystic fibrosis should also be tested, and these patients will be referred to a CF clinic. All right, so on to pneumonia. First, we'll kind of describe how to differentiate between bacterial and viral pneumonia. So bacterial pneumonia has an abrupt onset. The patient appears ill or toxic. They may experience chills, moderate to severe respiratory distress, and then you'll have focal oscillatory findings on exam. If you do blood work, they could have a WBC elevated above 15,000. So diagnosis is made with a chest x-ray, and it may show infiltrates. A viral pneumonia usually affects a population younger than 5 years old. There's more of a gradual onset that begins with those upper respiratory symptoms. They don't appear toxic. And then on oscillatory exam, they have diffuse bilateral findings, perhaps wheezing. So less than 6 months with a suspicion of pneumonia, those patients should be sent to the ER. If they're greater than 6 months and they're stable, they can be managed outpatient. So first-line treatment for those patients is amoxicillin, and that's 90 mg per kg per day, divided into 2 doses times 10 days. No follow-up x-ray is needed if they recover as expected. And then a couple side notes here. If they're not fully immunized, you can consider Augmentin. And then if they have allergies to penicillin, here are some options for you as well. CROUP is an illness, a respiratory illness that may cause inspiratory stridor and a barking cough. X-rays are only indicated if the etiology is unknown. Otherwise, they are not needed. If they are done, you may see the steeple sign, which is tapering of the upper trachea, and this is a sign of CROUP. Children with mild CROUP, they can be managed outpatient. Generally, this illness is self-limiting. If you see them in the office, they can have a single dose of Decadron, which is 0.6 mg per kg. Moderate to severe CROUP, however, they need to be evaluated in the ER. Symptoms of severe CROUP include stridor at rest, marked retractions, and then just significant distress. Managing these patients, we need to be very cautious to keep their anxiety level at bay, because if they get really worked up, crying, screaming, this can actually worsen their airway obstruction and you're going to find yourself in a lot of trouble. So initial treatment should be nebulized epinephrine. Also, Decadron, again, is still recommended, and it's recommended to be given at the least invasive route. But for outpatient, this can wait until the ER, because if it's needed to be given by IM or intramuscular injection, this, of course, could upset the child, worsening the airway obstruction. So outpatient, your goal is going to be to give them the nebulized epinephrine, and then call for ambulance and keep them as calm as possible. All right, so on to the cardiovascular system. A few important key points here. Up at the top, I listed normal heart rate for our pediatric population. And then blood pressure screening, this should begin at 3 years old and then annually. So coarctation of the aorta, these patients will have symptoms of high systolic blood pressure in their upper extremities, and then diminished or even unobtainable blood pressure in the lower extremities. This has a high association with Turner syndrome, and diagnosis is confirmed by echo. So for dyslipidemia screening, if children have any one or more risk factors for premature cardiovascular disease, then we're going to go ahead and begin screening. And these risk factors include obesity, diabetes, hypertension, even a family history of cardiovascular disease. So for the children with risk factors, we'll begin their screening every 1 to 3 years. It's a case-by-case scenario at the onset of the risk factor. And then children without any risk factors, we'll do the dyslipidemia screening in between 9 and 11 years old, and then between 17 and 21 years old. And then the last point here is in regards to murmurs in infants and children. These are common, and most of which are totally benign. For example, the Still's murmur, where the murmur is louder when the child is still. So approximately 10% are considered significant. And there's clues here that a murmur is pathologic, words to look for on your exam, and then obviously things to listen for in practice. So diastolic murmurs are almost always concerning, harsh blowing quality, a grade 3 or higher. Hollow systolic timing increases in intensity when they sit upright, a gallop rhythm, a friction rub, systolic click, all of these are concerning for pathologic murmurs. And I actually did another video that goes more in depth about murmurs if you want to listen to it, but this gives you what you need to know for the pediatric population. Okay, so on to hematology. So first here we'll discuss lead toxicity, and it's recommended that we do lead testing for our children 12 months and then at 24 months. There's an increased risk for those who have lived in or visited a home or facility that was built before 1978, but specifically before 1960. Generally, these patients are asymptomatic, or they'll have non-specific symptoms, including fatigue or GI symptoms. An elevated blood lead level can be associated also with neurodeficits, and these are actually irreversible. So no amount of detectable lead in the blood is normal, and if we get a positive result, then we want to repeat the blood draw. In patients with an elevated blood lead level, then we also want to screen for iron deficiency anemia, as often these two problems are associated with one another, and the combination of the two can cause even more serious problems. And then also we want to ensure screening of any other children that might have been exposed and report this to the public health authorities. So a diagnosis of sickle cell disease is made in the presence of hemoglobin S. Diagnosis, it can occur at prenatal testing, newborn testing, or related to development of symptoms. Generally, infants, though, are healthy at birth, and they don't become symptomatic until their fetal hemoglobin declines, and that's up until about early childhood. Diagnosis is made generally using electrophoresis. There are other options here. And I included here the results for sickle cell trait versus sickle cell anemia. You don't need to memorize those. It was just for reference. For these patients, important that we refer them to sickle cell disease specialist, and that we keep them on their prophylactic penicillin. Oftentimes, they'll begin the prophylactic penicillin within the first 3 months of life, up until 5 years. And then after that, it's a case-by-case situation, but important in primary care that we keep them on this treatment. Acute lymphoblastic leukemia is the most common childhood malignancy, and they'll have symptoms like hepatomegaly or splenomegaly, lymphadenopathy, anorexia, fever, bleeding due to low platelet count, petechiae, musculoskeletal pain, and they could even present with a limp due to that. They may have, for the lymphadenopathy, lymph nodes will be generally non-tender, firm, and rubbery. And the general rule of thumb is that a 10 millimeter node is considered enlarged. There are a few exceptions to that 10 millimeter rule, and they're listed for you here. So a meta-analysis was done of over 3,000 children with leukemia, and more than half of those children had at least one of the following 5 symptoms, and that includes a palpable liver, palpable spleen, pallor, fever, or bruising. With blood work, obviously we'll get the CBC with diff, but we'll also want to pay attention to the blood smear, which will show lymphoblasts. And we're going to refer these patients to a pediatric cancer specialist. All right, so now we are moving on to gastrointestinal. And first up is pyloric stenosis. This generally occurs between 3 and 6 weeks, and it presents as a projectile, non-bilious vomiting that occurs immediately after being fed, followed by an infant demanding to be fed again because they just lost all of their nutrients. Also known as a hungry vomiter. In these patients, you might be able to palpate an olive-shaped mass in that right upper quadrant, and it's going to be easier to palpate immediately after the infant vomits. Although diagnosis is going to be confirmed with an ultrasound, and we're going to refer these patients for a surgical correction. All right, so gastroesophageal reflux is another common complaint in the pediatric population, and it's defined as an effortless regurgitation in an otherwise healthy infant, also known as a quote-unquote happy spitter. Typically resolves over that first year of life, although you can trial removing cow's milk from their diet, as cow's milk protein intolerance can actually mimic gastroesophageal reflux. And symptoms of cow's milk protein intolerance includes blood in the stool, eczema, poor weight gain, and then a family history of atopy increases the risk. Also, we're going to want to encourage avoiding tobacco smoke as always, but in particular, this can worsen the symptoms. Intussusception is the most common cause of obstruction in infants, and it occurs most commonly between 6 months and 36 months. And it's described as the intestine telescoping in on itself, and it causes very sudden, intermittent, severe abdominal cramping. The patient might have inconsolable crying, suddenly draw their legs up towards their abdomen. They might experience things like current jelly stools as the obstruction worsens. And then you might also be able to palpate a sausage-shaped abdominal mass on the right side of the abdomen. Ultrasound, again, is going to confirm this diagnosis, and it may show something called quote-unquote coiled spring appearance. And for these patients, we're going to refer as well. The most common cause for viral gastroenteritis is going to be rotavirus, and this generally lasts about 5 to 7 days. Symptoms include an increased amount of stooling, usually 3 or more episodes, described as loose or watery in 24 hours, with or without fever, and the stool is absent of mucus or visible blood. It's spread by the fecal-oral route, and dehydration is going to be the complication that we really want to focus on preventing. So we'll want to encourage things like Pedialyte or a quote-unquote commercially prepared electrolyte solution. Signs and symptoms of dehydration that we want to look out for include an increased heart rate, dry mucosal membranes, sunken fontanelle, sunken eyes, reduced skin turgor, or reduced urine output. And then also important to note is that tachycardia might actually be the first sign of hypovolemic shock in infants. Next up is appendicitis, which is the most common cause for emergent abdominal surgery in childhood, and it most often occurs in the second decade of life. Initially, symptoms might be nonspecific, including indigestion, anorexia, and it generally starts with a periumbilical pain at first that eventually localizes to that right lower quadrant. Nausea and vomiting might occur after the pain begins, and fever usually doesn't come until about 24 to 48 hours after the onset of symptoms. Patient will have rebound tenderness at the McBurney's point, and the abdominal pain can be elicited by having the patient cough or hopping. Ultrasound is going to be used to confirm diagnosis, and important that if we have a high suspicion for appendicitis in our patients, then we'll refer to the ER before having any imaging done. Moving out of gastrointestinal and on to genitourinary, this is the slide about hydroceles and variceles. So hydrocele is a collection of the peritoneal fluid in the scrotum, and with the use of transillumination, we'll see that fluid collection. Important with these patients that we also assess for an inguinal hernia. There's 2 types of hydroceles. One is communicating and one is non-communicating, and that picture down below really shows, I feel like, a good depiction. So a communicating hydrocele, this one will possibly increase in size during the day or if the patient does the Valsalva maneuver. Generally, this will resolve by the first, maybe second birthday, but if we have these patients and it's not improved by the first year, then we want to refer them because it may require surgical repair. And then for the varicose, this is dilated veins. It can feel like a bag of worms, is how they describe it. The patient might experience a dull aching or sensation of fullness in the scrotum, and it's best to first assess this with the patient standing up. Up to about 95% of these occur on the patient's left side. However, if the patient has an acute onset of pain, or if the varicose occurs on the right side, or if the varicose will persist as the patient lays down, then we'll need to get an ultrasound, and these patients will be referred to urology. Alright, so cryptorchidism, this is also known as an undescended testes, a testis that does not descend to the scrotum by 4 months of age. You might notice it's empty, poorly rugated. If testes don't descend by 4 months, then this will generally require a surgical intervention. Of course, we'll be referring those patients out. Also important that this increases the risk for testicular cancer in the patient's future. If we suspect that our pediatric patient has a urinary tract infection, then we want to treat empirically against E. coli and wait for cultures to come back. Aggressive antibiotic treatment is because we're trying to prevent pylo from occurring in these patients. The first line treatment is a cephalosporin, cephalexin if there's no renal involvement. And then for the duration of time, antibiotics for 5 days if it's the patient's first UTI and they're older than 2 years old. However, if the patient is febrile, has a history of urinary tract infections, or they're younger than 2 years old, then it's recommended to do antibiotics for 7 to 14 days. A WILMS tumor is the most common renal malignancy in children, and it's one of the most common malignancies in all of childhood. It occurs before 10 years of age, but 3/4 of those cases occur before 5 years old. So an abdominal mass can be palpated, but it rarely crosses the midline. And if you look at the picture and you know the kidneys, you understand that if it's crossing the midline, there's some serious problems. Important, once a WILMS tumor is suspected, it's very important that we do not palpate that area, as it can result in rupturing the capsule and then spilling out the contents from the tumor. So patients might be asymptomatic, or they could have symptoms including abdominal pain, hematuria, or hypertension. Ultrasound is going to be your initial tool to help diagnose. There's a biopsy done to confirm diagnosis, but these patients are going to be referred. Okay, so leaving the genitourinary and onto musculoskeletal. And this first slide here is dedicated to assessment of the spine. So scoliosis is a lateral curvature of the spine, and it's defined by greater than 10 degrees when using the Cobb angle. Curvature during rapid periods of growth are going to be a big concern because this can cause serious and permanent deformity. Rapid curve progression and significant pain are signs of pathology. So you'll want to inspect your patient from behind. You'll have them stand in front of you and bend forward, touch their toes, and differences in the shoulder heights may be seen, asymmetry in the waistline. You'll get an x-ray to confirm diagnosis, a PA, and a lateral view. And then I included on that right-hand side, not really related, but still spine, important with examining our infants. And we're looking for things like a sacral cleft, a sacral dimple, or a tuft of hair, hemangioma, skin discoloration, anything at that sacral area, because this could be a concern for an issue with the spinal cord, and we will want to get an ultrasound of that. So this slide covers Osgood-Schlatter's disease, and never mind the little red squiggly under that. I could not convince my computer that that is how that word is spelled, but it is osteochondritis of the tibial tubercle, and it causes anterior knee pain and swelling. So it occurs most frequently in children between 9 and 14 years old, and more frequently in those that are active in sports. So really managing this is very conservative. We can recommend that they ice the area after sports to decrease the swelling, which will help with pain. We can do analgesics short term, and they can still continue with their sports if their pain resolves within 24 hours. And if needed, we can recommend physical therapy. Screening for hip dysplasia is going to be really important in examining our infants. It should occur soon after birth and then at every visit until they're 9 months old or until the child is walking independently. Checking for instability by using abduction and elevation, also known as the Barlow and Ortolani test. If there is a sensation of reducibility or if you feel like a clunk sensation that requires further workup, you would get an ultrasound to further assess that. And then there's something called the Pavlik harness, which is used for infants 6 months and younger, and that's to help correct the hip dysplasia. All right, so we are leaving musculoskeletal and heading into common skin findings that we'll see in infants. There's something called amelia, which are these white little papules due to trapping of keratin or sebaceous materials, and there's a good picture there for you. Generally found across the nose and or on the cheeks. They're benign, they resolve without any intervention, usually within the first few weeks of life. And then this, on the other side, on the right-hand side here, is miliaria. And I remembered this by remembering the R in miliaria by really ridiculously roasting hot. It helped me. It's a heat rash, a temporary eruption of the skin related to heat, and then the obstruction of sweat glands. Treatment is moving the patient to a cooler climate or dressing them in more breathable clothing. Miliaria rubra is the most common form, and that is what that picture is of there. Other treatment options, they include topical corticosteroids twice a day for 1 to 2 weeks to decrease the itching, and then topical antibiotics are going to be indicated if there is pustulence present. More common skin benign findings in infants includes sebaceous hyperplasia and erythema toxic neonotorum. So sebaceous hyperplasia are white or yellow papules, mostly found on the face, nose, and upper lip, and this resolves spontaneously over the first few weeks of life without any intervention. And then erythema toxic neonotorum is common. It's pustules that appear in the first 72 hours of life. They more frequently occur in the larger for gestational age population. Initially, the patient experiences 1 to 3 millimeter in diameter macules or papules, then that quickly transform into erythematous pustules. Generally, this starts on the trunk and then it spreads, sparing the palms and the soles. This is also self-limiting and no treatment is required. So 2 more common skin findings in the pediatric population, one being the congenital dermal melanocytosis, also known as the Mongolian spot. This is common in the Asian, African American, and Hispanic neonates. Generally, it'll appear as a blue, gray, or brown patch with ill-defined borders, generally on the sacral area, but also on the shoulders. Rarely does it appear on the head. And by 6 to 10 years old, most of them have disappeared. The cafe au lait macules, those are benign, flat, pigmented lesions, somewhere between tan or dark brown. They're either present at birth or appear early on in childhood and distribute over the trunk and the extremities. The palms and the soles are unaffected, however, and they range from either a few millimeters to greater than 15 millimeters, and they grow as the child grows. All right, so this slide here covers mononucleosis, and this is an acute illness due to the Epstein-Barr virus. It's most commonly seen in adolescence or young adulthood, and it spreads with intimate close contacts. So we'll see a triad of fever, tonsillar pharyngitis. We might see tonsillar exudates that are white or grayish green or even necrotic appearing, and then lymphadenopathy. If we have a suspicion for mono, then we'll go ahead and we'll test for that, but we'll also want to evaluate for strep. Mono generally requires only supportive therapy. So also there's some symptoms that we want to look out for. A maculopapular or urticarial or petechial rash might occur, and sometimes this rash is mistaken as a penicillin reaction, as sometimes this antibiotic is incorrectly prescribed, and then the subsequent rash that occurs is mistaken for an allergic reaction to penicillin when it's actually just a symptom of the mono. We also might see splenomegaly, and this is a concern because we don't want a splenic rupture to occur. More than 50% of patients that experience splenomegaly will experience this within the first 2 weeks of their illness, and therefore the research recommends a minimum of 3 to 4 weeks off from any sports to avoid precipitating an event with the spleen. So if it's non-contact sports, then 3 weeks should be sufficient. However, if it's contact sports, then a minimum of 4 weeks off. And then we'll want to get an ultrasound to confirm resolution of the splenomegaly before they're able to return to sports. And then there are some more rashes and viral exanthems that are important to know for the pediatric population, but I've already covered them pretty thoroughly in episode 5 of this series, so I'll just refer you there. So go ahead and check that out. But to avoid making this like an hour-long presentation, I'm just going to refer you to that instead of reiterating them again. Wow, so miraculously we have made it to the end of this discussion. This is one of two of the dump sheets here at the end for you. I tried to shorten it up and focus on just those clinical pearls and key points that you really want to hone in on. I know regardless it's still a lot there, but hopefully it helps you to really focus on the important stuff. So that's the first slide there. All right, so here is page 2 of 2 for the pediatric dump sheets. Go ahead and screenshot, print, and look those over. As always, leave me any comments or questions down below. And don't forget to subscribe if this is helping you in your studying. And until next time, I will talk to you guys soon. Bye.